am going to invite for this evidence-based medicine. He is a renowned person already. You know, if I took his name, you will recognize that the whole portfolio of that person with his name. His name is enough. But I will say, खुद ही को कर बुलंद इतना कि हर तकदीर से पहले खुदा बंदे से खुद पूछे बता तेरी रज़ा क्या है. He is working on the khudi, the psychological aspect of the khudi, and he is having a series of YouTube lectures where he is telling you what is behind the neurosciences of every emotion and how to achieve the self-awareness. So this chapter, this lecture is one of the component of that thing, that you must recognize your potential and you should identify, you should be self-aware what you are writing, how you are writing. So I would like to invite the Professor Mowadat Rana. He is FCPS, MRC, FRC Psych. He is gold medalist. He is honorary chair in many, I was searching, he was honorary chair in many institutes, in many positions, even in UHS. He is dean, honorary dean, and he is having uncountable research articles. He have written a textbook. Very few people have written the textbook. He has written the textbook of behavior sciences. And other thing, he got the Stara Imtiaz. No one among us had got the Star Imtiaz. Ladies and gentlemen, please welcome Professor Mowadat Rana.
Bismillahirrahmanirrahim. Honorable Chair, Professor Javed Akram, dear friends, colleagues, what a huge honor it is to be invited to the Society of Internal Medicine's conference. It's not often that psychiatrists get this privilege of finding their lost resource in medicine. In many ways, we are a bridge between the psychosocial care and the biomedical model of practice of medicine. So when my very dear friend, my old-time buddy from medical education, Professor Aftab Mohsin, asked me to be part of this activity, I felt hugely privileged and honored. And then I asked, what is the theme of the conference? And he said, evidence-based medicine up now. So I sent him probably my title of the talk within about 10 or 15 minutes or so of that particular iconic theme of the conference that he had chosen for this activity. Long time ago, 1977, ladies and gentlemen, many of you wouldn't have arrived in this world, particularly the females in the hall would not have been around, surely. So around that period of time, I was waiting for my admission into the medical college, and suddenly got a call from Army Medical College to join, which was in Rawalpindi, and we were to go there as the first batch of Army Medical College. I had not left home by that time, and was so used to the comfort of living with my parents that it immediately struck me that from here on, I am going to leave my Apne. But the stare in the look of my parents said, out you go. I think they had had enough of it by that time because of my long hair and rather a wild state of mind that I used to have at that point in time. So I was thrown out into the realm of Army Medical College and hostel life, and I immediately felt that the first movie that I'm going to see, which was coming around that period of time, was titled this, Apne, Huwe, Paraye. Probably Professor Javed Akram might remember this movie from 1970s. The reason not only was the title of the movie, but also because of the fact that Sangeeta had recently come into the film industry and I was one of her fans. Amongst the millions of Pakistanis, she was a heartthrob of that time. If you see today's Sangeeta, you wouldn't recognize the Sangeeta that we had seen in those times. So I went to see this movie. But all that I really focused was Sangeeta. Didn't really saw much of the rest. Up now, evidence-based medicine, ladies and gentlemen, brings to you many questions. And probably those of you who are sitting here in this hall are going to see more and more of millennial and Generation Z postgraduate medical trainees as well as undergraduate medical students asking you questions which we as the baby boomers were not supposed to ever. The professor was a demigod in our times. So when he looked at us, we trembled. But today's medical student, today's postgraduate trainee is far cry away from that model of the teacher and the taught. And if you haven't come across this particular scenario so far, I can assure you that you would. Just have a read of this scenario. Now this is from psychiatry, but I'm sure this is not a very unfamiliar situation. This is something that has happened and is a reality. Just read through it, probably with the lens of a physician. Have you read it? Okay, I can surely tell you what would have happened in 1980s. This was the last day of this training, on the training. But while you're reflecting on what would happen now in this situation today, I remind you of this movie. I later on realized that there was much more to this movie than Sangeeta. So similarly, you would realize that there are more and more stakeholders and players today in evidence-based medicine than what we used to have at that point in time earlier in my career, and probably many careers in this hall. Have you thought about this particular scenario that I had just posed to you, this particular scenario? Now, what do you think would have happened? Suppose this is an undergraduate medical student, not a postgraduate medical student. Would the professor of today have the guts to tell him to get out? No, sir. He has just deposited more than $1 million as his annual fee. And how dare you say that? So this is a changing word, sir. Anything and everything today is fluid. There's nothing like gospel anymore in medicine. And I'll try and show to you that for all practical purposes today, even evidence-based medicine is not a gospel. And in the next couple of minutes that I have at my disposal, I'll try and highlight to you some pitfalls and some things to remember while you are in a state of up now. Keep few things in mind, and you would find that you are now going to deal with more and more Apne who are going to get Paraye during the course of their trainees. There are several difficulties with evidence-based medicine, ladies and gentlemen, and I'd be very happy to share the references that I've used to compile these cons in front of you. Have a read of them. Now there are more and more challenges looking at the meta-analysis that have come out and have been used in guidelines. And more pitfalls in the design of our cities are being found. And there are today many who would challenge the authenticity of a randomized controlled trial, which for you and me is a gold standard. Or is it not? This is the gold standard. And this is what we use in meta-analysis. So the issue is, if you're going to use a defective RCT to develop a guideline, what will happen to those who will adopt that guideline? So surely RCTs is no more the final word. It's being challenged around the world, the authenticity of RCTs. Now, the second query here is, can you have an RCT on virtually every scenario that you and I are going to face? Let us look at the life of somebody who is in Thal desert somewhere practicing medicine. And that is a situation that is going to arise in the days to come. Can he borrow a recommended guideline from NICE to be practiced in Thal, in those realities? That's a question that you can sit and ponder on. Is this professor not feeling challenged that his whole experience is being challenged through a mechanistic reasoning offered in the smartphone? Yes, sir, ye aap kya kar rahe hain? Ye dekhiye kya guideline mein likha hua hai. So what is going on in the mind of this gentleman who has spent about 30, 40 years of his life in medicine, or in psychiatry for that matter? The values of the patient, the local patient. What are his values? What is his understanding of chemotherapy? What is his understanding of a drip or an injection? How does he interpret the recommendations that are made in evidence-based medicine? So these are challenges that you need to keep in mind. Is this really an ivory tower? Hard to climb. Ungettable sometimes. Those standards that are set somewhere in the corridors of power in the West, तो कहीं एविडेंस बेस्ड मेडिसिन भी किसी गुलामी की कैफियत का नाम तो नहीं है? आजकल गुलामी का बड़ा जिक्र है. There's a question to be pondered on. Think about it. Then of course is this issue. Health economics is one of the serious considerations when you're making an international guideline. So, which health economics are we talking about here? Where the allocation for a psychiatric patient in Pakistan today, would you be surprised, ladies and gentlemen, if I told you that Pakistan spends 1 rupee and 8 annas? I would still like to stay in annas because it's ridiculous the amount that you're spending on the mentally ill of Pakistan. 1 rupee and 8 annas today. While we are making institutes for liver and kidney transplants and heart transplants and whatnot. That's what you spend on mental health. So, health economics. Every guideline that you would pick up is going to emphasize primarily on the medication or some intervention that has been recently devised, a radiological intervention or a surgical intervention, whatever you have. How many of those guidelines are going to emphasize on psychosocial care? Very few, probably. Very few. A largely biomedical model that is still in practice, although we know that the biological reality of disease is probably grossly overestimated in many clinical situations. And you know it and I know it. But probably the easiest way out is to just focus on the biomedical concepts in a patient's life and prescribe and tell him to leave your office. Our way of telling our patients to get out of the clinic is to hand him over your prescription. It's your way of saying goodbye to him. Ye lein aur jaएं. and rest could be history. Now, recently when we were fighting the COVID-19 crisis, were we not really actually killing patients and then learning from why they got killed? Many of them died, you and I know, of iatrogenicity rather than the virus. And please do tell me if I'm wrong at the end of my talk. Did we or did we not contribute towards the accelerated death of our patients in COVID-19? Why? Because we didn't have any evidence-based medicine to practice. So we were learning as we went. And nobody is going to undermine that colossal effort that the medical community has made in fighting this menace. And I'm not here to undermine that. But let us look a little deeper and search a little deeper into our souls while we are reflecting on the practice of pulmonary medicine that went around at that point in time in COVID-19. Now, before you start to consider me an anti-science psychiatrist, there are several advantages of evidence-based medicine. So I'm not challenging that don't apnao. There are several advantages listed in front of you here. And what I love most about evidence-based medicine is that it will probably let every prisoner who develops thrombolytic issues and platelet count disturbances to go out of Pakistan whenever he or she develops that kind of an issue. That's what the equity of evidence-based medicine is. It doesn't distinguish between the powerless and the powerful. The great equalizer that evidence-based medicine is. So don't think that I'm challenging its authenticity. No, there are. Obviously, the empiricism that is shown is very democratic. What do? You take out the best evidence, a particular intervention, when you are about to introduce it into the guideline, you democratize the RCTs. And then you bring in the one that has gotten the maximum votes. I've always wondered how empirical actually science is going to be if it starts to vote for what is right, rather than think philosophically of what could be right. There's a lot of difference between the two, and it's a subtle issue, ladies and gentlemen, that I'd like you to reflect upon. In some ways, we are democratizing science. There are more people saying this, let's believe it. Democracy is fine, but remember, it is the best of the worst ways of governing. Many political scientists will tell you that this is the best out of the worst, or the worst out of the best. That's what democracy is. And you are about to bring it into science, into empiricism. So therefore, it might be a good idea to actually review the whole concept of empiricism being challenged by democracy, and how the two are going to interplay now, and how they are going to interact, and what will be the sons and daughters of this marriage of convenience between democracy and empiricism. Again, a question that you need to sit and ponder. Probably I'll leave more questions for you than I answer by the end of this talk. My serious issue is that if a clinical trial proves a pathophysiological theory wrong, would you have the power, would the professor of physiology and professor of pathology prevail upon the evidence-based guideline? Because it has challenged the pathophysiology of that particular disease? Do you think there's any pathophysiological basis of the use of H2 blockers in every patient who comes to tell you कि मुझे खाना खाने के बाद डकार आते हैं और मेरे पेट में गैस हो जाती है? Is there a pathophysiological basis of prescribing omeprazole to this patient? You can call me an ignorant psychiatrist doesn't understand the pathophysiology of gastroenterology. But I did my MBBS. And I know that dyspepsia does not augur for a prescription of omeprazole. No, sir. Pathophysiology wouldn't support this idea. Yet you and I probably are writing omeprazole right, left, and center. Because the guidelines say, go ahead, you can give it in dyspepsia. Think about it. Would you be able to stand in the court of law and defend your action on the basis of a pathophysiological theory? Probably not. So, issue of bias in our studies. Now, how biased can a scientist be when the issues related to designing a Narcity depends upon the funding resources that he has? So one of the major issues today of research in the West is how much funds do you draw and from where? So would that introduce any kind of bias into your work, sir? Or would it not? Or was it just coincidental that all the prophets were poor? Try to connect the dots between the two. Now, do I have an answer to the professor? Yes, sir. I have a recommendation, not an answer. I think this is the time for all of you, the scholars of internal medicine, the brain of internal medicine in this country, to actually consider, as my teacher, Professor Bashir, used to say, please do not think that West is synonymous with best and East is synonymous with beast. No, it's not. There is probably more and more need to go to that physician who practices in Thal, and maybe he has some wisdom to teach you. It could be qualitative, not quantitative. He may not be able to design an Narcity sitting in those remote areas of Pakistan, but he might have accumulated wisdom that needs to be taken on board, which the RCTs lack or would never have. There is a need probably to bridge the gap. Right now, the one is clearly winning because of the democratization of the science, and the other is constantly losing ground. See, if you're not going to link up the two, the science will die, sir. Funds will win. And the truth that can be bought no more is truth. Please, costs and care, very important. But keep the concept of equity that I had raised earlier in front of you. Now, what can be done? It's a very humble suggestion by a student of medicine for you to consider. The Apne model, the Apnao model, what I would call a deliberative model of care. Can we ask this young trainee to come to your office? Can you ask the patient and the family to come to the office and sit around a round table where everybody is equal, and the professor no more is the demigod, and around this table are the possible stakeholders and the concepts that are playing role in generating disease in this patient. All brought around together. Look at the pluses here and see how many considerations are being made before you decide whether it is going to be clomipramine, SSRI, or CBT, which is a form of psychotherapy. Would it be only one of them? Could they all be combined? Could it be just SSRI? Could it be just CBT? Or can the wisdom of the professor prevail and clomipramine is the answer for this patient? But let it not be decided because the good professor thought so. And let it also not be decided because the postgraduate trainee represents the Young Doctors Medical Association. Let those not be the considerations when you make, ladies and gentlemen, a scientific decision. Let it be a judgment built around science, evidence, values of the patient, the realities of Pakistan. And above all, let this be an informed choice in the language that the patient and the family best understands. Ladies and gentlemen, thank you very much.